Welcome to the deep dive. Today, we're tackling a really critical piece of the puzzle for people living with end-stage kidney disease, keeping their arteriovenous or AV hemodialysis accesses working well.
Absolutely. These accesses are lifelines, truly.
They really are. And when they start to fail or, get blocked, it just throws a major wrench into their treatment.
It really does. It's not just a plumbing problem. It directly impacts how well the dialysis works, how consistently they can get that life-sustaining therapy.
So our goal today is to really dig into what makes these connections falter, how we can spot the warning signs early, hopefully, and what the options are for fixing them, keeping the blood flowing.
Right. We're pulling from Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition, solid source.
Definitely. Gives a great look at the reasons for failure, detection, the whole spectrum of interventions.
Yeah.
It's like getting the inside scoop on how clinicians manage these.
Exactly.
Okay, so let's start right there. What are the fundamental reasons why these AV accesses start having problems?
Well, the main culprit for both the patient's own vessels, the autogenous ones, and the synthetic or prosthetic accesses is something called intimal hyperplasia, IH for short.
Intimal hyperplasia. Okay.
Yeah, think of it as like an overgrowth of cells on the inside lining of the blood vessel. It's a bit like scar tissue, but inside the vessel.
Okay, so it builds up.
It builds up, and that narrows the channel. We call that luminal stenosis. And that obviously restricts blood flow.
And are there typical places where this IH likes to form? Hot spots, so to speak?
Yeah, there are. In prosthetic accesses, the grafts, it's very common right at the connection point between the graft and the vein. That's the venous anastomosis.
Makes sense, that connection point.
And for the autogenous accesses, the fistulas made from your own veins, it often happens in what they call swing segments. These are the parts of the vein that were surgically moved, kind of swung over to connect to the artery.
Oh, okay.
But interestingly, you can also get stenosis further up in the big central veins like the subclavian, even without a history of catheters there before.
So what actually kicks off this intimal hyperplasia? What starts the overgrowth?
It's thought that the initial triggers are, well, twofold, really. The trauma from the surgery itself to create the access.
Right, the initial procedure.
And then the changes in blood flow patterns, particularly the shear stress that's the friction of the blood flowing against the vessel walls, especially in these high-flow systems. This basically triggers a biological response.
And it varies a lot between people.
Hugely. Some patients get really aggressive IH formation quite quickly, while others, it's much slower, much milder. We're still figuring out exactly why that variability exists, but it's a super common issue.
So that IH leads to stenosis. And the main problem with stenosis is reduced blood flow. Why is getting enough flow so critical here?
It's absolutely vital. The access has to deliver enough blood to the dialysis machine to clean it effectively. Think about it. The dialysis machines, they usually pump blood at maybe 450 milliliters per minute, but you need the access to supply more than that, significantly more, usually aiming for somewhere in the range of 650 to 1,000 millimin.
Why so much more? Is it just a buffer?
It's mainly to prevent something called recirculation. You don't want the machine pulling in blood that's just been cleaned and returned to the body through the other needle.
Ah, I see. You'd just be cleaning clean blood.
Exactly. It makes the whole dialysis session less efficient. So you need that higher flow coming from the access to make sure the machine is drawing fresh, unfiltered blood.
And does the patient's heart function play into this?
Oh, definitely. Adequate cardiac output is key. If someone's heart isn't pumping strongly, the access flow might actually drop during dialysis as fluid is removed.
Yeah.
That can really compromise how well the treatment works.
Let's talk more about that recirculation problem. How exactly does it mess up the dialysis?
So you have two needles, right? An arterial needle drawing blood out to the machine and a venous needle returning the clean blood. Recirculation happens when the arterial needle accidentally sucks up some of that freshly returned, already cleaned blood from the venous needle.
Okay.
Because that blood has fewer waste products in it, the machine doesn't remove as much waste during that pass. It lowers the overall efficiency. You might need longer dialysis times to get the same cleaning effect.
And you mentioned different kinds of stenosis causing this. Venous outflow and arterial inflow.
Correct. Venous outflow stenosis, that's a narrowing in the vein carrying blood away from the access, often shows up during dialysis as really high pressure readings on the venous line. The machine usually alarms if it goes above, say, 300 millimeter Hg.
So the staff would notice that alarm.
Right. They might try adjusting things, maybe slow to pump speed down, but the underlying stenosis is still there, and it can cause recirculation, lower the dialysis effectiveness. We measure that with KTV, cause prolonged bleeding from the needle sites afterwards, make the access feel overly pulsatile, or weaken that buzzing feeling, the thrill.
Okay, so high venous pressure is a big clue for outflow problems.
Huh.
What about the inflow side, arterial stenosis?
Arterial inflow stenosis, that's a narrowing before the access in the artery feeding it, that limits the total amount of blood getting to the access in the first place.
So both needles are kind of downstream from the blockage.
Essentially, yes. On physical exam, you might feel a weak pulse or a weak thrill. And a key sign is poor augmentation. If you squeeze the outflow vein, the thrill doesn't get stronger like it should.
Ah.
And during dialysis, the arterial pressure reading on the machine will be highly negative. The pump is struggling, sucking hard to pull enough blood through that narrowed artery.
So a lot of these clues pop up right there at the dialysis center.
Absolutely. The dialysis team is often the first line of defense in spotting these things.
Now, besides the stenosis itself, what about the needle sticks? Can the cannulation process cause issues?
Oh, definitely. Needle placement is critical. If the tips of the two needles are too close, usually less than about 3 inches apart, you can get recirculation even without a major stenosis.
Why would they be too close?
Could be several reasons. Maybe there just isn't enough straight, usable length in the access vein, or perhaps the access is too deep under the skin, making it hard to rotate needle sites properly.
Okay.
Also, things like aneurysms or pseudoaneurysms, those ballooned out sections of the vessel can cause problems. Blood can pool and become stagnant in large ones, contributing to recirculation. And there are weak spots prone to infiltration or bleeding when cannulated.
And sometimes, even if the flow seems okay, just getting the needles in is a problem.
Exactly. If the vein is just too deep, say more than 6 millimeters down, or if it's too small in diameter, maybe under 5 millimeters, it can be really tough to stick reliably.
Even if the flow rate is technically good.
Right. This happens a lot in patients with obesity. The vein might be a decent size, but it's buried under too much tissue. In those cases, a surgeon might need to do a procedure to bring the vein closer to the surface, a superficialization or elevation.
Okay. So have IH cannulation issues. Are there other, maybe more systemic things that cause access failure or clotting, thrombosis?
Yes, several. Things like systemic hypotension, low blood pressure overall, underlying blood clotting disorders, thrombophilias,
Wow.
limited cardiac output, as we mentioned.
Right, the heart function.
Also, just the repeated trauma from sticking needles in the same area over and over can contribute. And then there's dialysis access-related steal syndrome.
Seal syndrome.
Yeah, where the access steals too much blood flow from the hand or arm, causing pain, coldness, even tissue damage sometimes. That might need surgery just to reduce the access flow. And don't forget, central venous stenosis. Narrowing of the large veins in the chest, often caused by previous catheters or pacemaker wires, things like that. It might only become obvious after a high-flow access is put in because the central vein just can't handle all that extra blood flow trying to get back to the heart. That leads to arm swelling, venous hypertension. Often happens near the collarbone, the thoracic outlet.
So even things done for other reasons can impact the access later.
Exactly. And finally, let's be honest, the very act of repeatedly puncturing the access for dialysis week after week inevitably causes some degree of injury and contributes to that intimal hyperplasia over time. It's a constant battle.
It really sounds like it. Okay, so given all these potential problems, how do doctors and nurses figure out when an access is starting to fail? What's the detection process?
Well, it's really a combination of things. Information from the dialysis unit is key. Physical examination is crucial. And then there are specific clinical signs during treatment.
So what kind of info comes from the dialysis center?
They're the ones seeing the patient regularly. They'll report things like, is it becoming difficult to insert the needles? Are the venous pressures consistently high? Is there prolonged bleeding after needles are removed? Are the recirculation numbers going up? Is the arterial pressure excessively negative? All those clues we talked about.
Right, the practical hands-on observations. And the physical exam, what does that involve?
It starts with just looking inspection, checking the skin over the access. Any redness, scabs, signs of infection, thinning skin. Is there swelling in the arm, hand, or even the chest wall, which might suggest a blockage further up? Are there lots of prominent veins on the chest or shoulder collaterals trying to bypass a blockage?
Okay.
For a fistula, if you raise the arm, it should normally collapse somewhat. If it stays bulging and distended, that points to an outflow problem.
And then feeling the access palpation.
Exactly. You feel for the thrill, that buzzing or vibration. A healthy access usually has a continuous thrill that you can feel extending along the vein. It should feel relatively soft and compressible. If it feels really hard and pulsatile, like a hammer beat, that suggests high pressure from an outflow stenosis downstream.
Can you pinpoint the stenosis location that way?
Sometimes. If the thrill kind of disappears or changes character abruptly, the stenosis is likely right around that point. If there are aneurysms, you'll feel those localized bulges, often pulsatile.
And listening with a stethoscope. Auscultation.
Yep. A healthy access typically has a continuous, low-pitched whooshing sound, the bruit. If the sound becomes high-pitched, especially if it's only heard during the heart's contraction phase, systole, that's often a sign of a significant narrowing, a stenosis.
So a good physical exam can tell you a lot.
A trained clinician can pick up a surprising amount just by looking, feeling, and listening, absolutely.
Are there other clinical signs beyond the physical exam and dialysis machine readings?
Sure. Things like the patient reporting pain during cannulation. A documented decrease in how much dialysis they're actually receiving, that KTV number falling off. Inability to consistently run the dialysis machine at the prescribed blood flow rate. And, as mentioned, that prolonged bleeding after needle removal is a pretty common sign of high venous pressure due to outflow stenosis.
So if these signs appear, especially together, it warrants a closer look.
Definitely. That's usually the trigger for more formal investigation, maybe with ultrasound or an angiogram, to find the specific problem before the access clots off completely.
Let's talk about a specific issue, failure to mature. When a new fistula just doesn't develop properly, what's supposed to happen?
Ideally, a new fistula needs time to mature, basically. The vein needs to enlarge, and the wall needs to thicken up enough to handle repeated needling. We generally look for a diameter of at least 5 millimeters, maybe even 6, and blood flow of at least 500 millimines, sometimes more. This usually takes about 4 to 8 weeks.
But it doesn't always happen.
Unfortunately, no. Failure to mature is pretty common. Rates can be anywhere from 20% up to, 60% in some studies. It's a major issue.
Wow, that high.
Yeah. But the good news is many of these can be salvaged if we intervene early. That's why it's so important to check them around 4 to 6 weeks after surgery if they aren't developing well.
What are the signs it's not maturing properly?
You might feel a weak pulse or thrill. That poor augmentation sign we talked about, squeezing the outflow, doesn't make the thrill stronger. Maybe you hear a high-pitched sound near the arterial connection, suggesting an inflow problem.
An ultrasound can help figure it out.
Ultrasound is really useful here. It can measure the vein diameter directly, measure the flow volume, and look for any specific blockages or stenoses that might be hindering development.
What else can go wrong with maturation?
Sometimes there are side branches, smaller veins coming off the main fistula vein that are basically stealing the blood flow. They divert the pressure and flow away from the main channel so it doesn't enlarge properly.
So the flow goes down the wrong path.
Exactly. Those might need to be tied off or coiled, blocked surgically, or sometimes percutaneously to force the flow down the intended path.
And we talked about depth earlier.
Right. Even if the vein gets big enough, if it's too deep or in an awkward spot, or if there isn't a long enough straight segment, it's going to be difficult or impossible to cannulate safely. And trying to stick fragile, immature veins, well, that can cause damage, infiltrations, hematomas.
Leading to more problems.
Exactly. That's why having experienced staff cannulate new accesses is really important. And good communication between the surgeon and the dialysis unit is vital to troubleshoot any issues early.
Okay. Now, what about checking on accesses that are established and working? Is there routine testing or surveillance?
That's a bit controversial, actually. The main guidelines, like KDOQI, generally don't recommend routine, scheduled surveillance testing for all accesses in all patients.
Really? Why not?
Because the evidence hasn't consistently shown that doing routine tests and then fixing any mild narrowings found before they cause symptoms actually improves the overall lifespan of the access for everyone. It might lead to more procedures without clearly preventing thrombosis in many cases.
So intervention based on clinical signs is preferred?
Largely, yes.
Yeah.
Clinical monitoring, the physical exam, the dialysis parameters we discussed is the cornerstone. But there are surveillance techniques used in some centers or when there's a clinical suspicion.
What are those techniques?
Well, one is venous pressure measurement. They can measure the static pressure inside the access when the pump is off. Comparing that pressure to the patient's blood pressure gives a ratio. A high ratio, especially if it's trending up over time, particularly in grafts, can suggest an outflow stenosis and might trigger an angiogram.
Okay.
Another method is measuring the actual blood flow rate in the intra-access flow. This is more objective than just feeling a thrill. Techniques like ultrasound dilution are common. They inject saline and use ultrasound to see how quickly it dilutes, which calculates the flow.
What flow rate is considered problematic?
For prosthetic grafts, a flow rate dropping below about 600 millilmin is often seen as a warning sign, increasing the risk of clotting. The thresholds for fistulas are generally lower and less well-defined. But again, KDOQI mainly recommends clinical monitoring for grafts and referral if flow drops below 600 or drops significantly, say more than 25%, from the patient's usual baseline.
What about using duplex ultrasound for surveillance?
Duplex ultrasound combines imaging with flow velocity measurement. It can definitely identify stenosis. A sharp increase in velocity across a narrowing is a key sign. It's very useful for confirming physical exam findings or figuring things out when the exam is tricky, like with multiple aneurysms. It can also measure flow volume.
But not necessarily for routine screening of everyone.
Right. For routine screening, especially in fistulas, it's not clear it adds enough value beyond a good clinical exam in many cases. It's often used more selectively when there's a specific question or concern.
And catheter-based angiography, you inject dye and take x-rays. Is that ever for surveillance?
No, not really for surveillance. Angiography is invasive. You have to puncture the access. It's primarily an interventional tool. You do it when you strongly suspect a problem based on clinical signs or other tests, and you're likely planning to fix something at the same time.
So it's diagnosis and potential treatment together?
Exactly. You find the lesion, you can often treat it right then and there with balloons or stents. It avoids the delay and the risk of the access clotting while waiting for a separate procedure.
Okay, that makes sense. So we've covered failures and detection. Let's move on to fixing things, the interventions for a failing access, one that hasn't clotted yet but is showing signs of trouble.
Right. The interventions basically fall into two main camps: open surgical techniques and percutaneous or endovascular techniques done through needle sticks. And sometimes you combine them in a hybrid approach.
Let's start with surgery. What are the common open repairs?
For a stenosis, the main goal is to widen that narrowed segment. First, you need good imaging, usually fluoroscopy with contrast dye, during the surgery itself to see the whole circuit from artery to heart and pinpoint the problem spots.
See it in real time.
Yep. Then the repair itself might involve cutting out the narrow section and putting in a short bypass graft, an interposition graft, either synthetic or vein. Or they might do a patch angioplasty, slicing the vessel open lengthwise and sewing in a patch to make it wider. Both work. Studies show pretty comparable results long term.
And surgery for other issues besides stenosis.
Sure. If those side branches are stealing flow from a fistula, a surgeon can tie them off ligation or maybe coil them. If an access is too deep, especially in obese patients, they can do that elevation or translocation procedure we mentioned, moving it closer to the skin.
Like the second stage of a basilic vein transposition.
Exactly. Similar techniques. Either debulking the overlying tissue or sometimes completely rerouting the vein through a shallower tunnel. Any other issues, like aneurysms needing repair, can often be addressed surgically at the same time.
Okay, now the less invasive options, percutaneous techniques.
These are generally similar to procedures done elsewhere in the body, like for leg arteries. But you have to remember, the stenosis in dialysis access, that intimal hyperplasia, it's different from typical atherosclerosis. It's more rubbery, fibrotic.
Doesn't crack open as easily with a balloon?
Right. It tends to tear or recoil rather than nicely dissect. So you often need different approaches.
Balloon angioplasty POB is still common though, right?
Oh yeah. Plain old balloon angioplasty is the workhorse. You thread a balloon catheter across the narrowing and inflate it, often to very high pressures, trying to stretch it open. Sometimes 20 atmospheres or more, much higher than typical arterial work.
Wow. Does that high pressure cause problems?
It can. It can potentially damage the vein wall and actually stimulate more IH growth, leading to restenosis later. It's a bit of a catch-22.
Are there ways around that? Cutting balloons.
People have tried cutting balloons. They have tiny blades that score the stenosis before you use the main balloon, hoping to get it open with less pressure and trauma. The results in trials have been kind of mixed, though. No clear winner over high-pressure Pioba consistently.
What about drug-coated balloons?
That's a big area of research. Balloons coated with drugs that suppress cell growth, aiming to reduce that IH response. Results are still coming in, some promising, some less so. It's evolving.
And you mentioned balloon-assisted maturation, BAM, earlier, for fistulas.
Right, that's specifically for fistulas that aren't maturing. It involves doing serial angioplasty procedures maybe a few weeks apart, gently dilating the vein with progressively larger balloons to encourage it to expand. Early intervention seems key, but the long-term impact on access survival is still being studied.
When do stents come into play for failing accesses?
Stents provide scaffolding to hold the vessel open after angioplasty, especially if the balloon alone doesn't do the job or if there's a tear, a dissection. But standard bare metal stents, just the mesh tube, tend to get IH growing through the mesh, causing in-stent restenosis.
So they aren't used as much now?
Less favored for the main access conduit, yeah. Covered stents, those stents with a fabric covering, are different. They block that tissue ingrowth. They've shown better results, especially for those tricky venous anastomosis stenosis in grafts.
But they're more expensive.
That's the main drawback, cost. They can also be useful sometimes to salvage a graft with a big pseudoaneurysm or degenerated segment, kind of relining it. But you generally shouldn't cannulate directly through a covered stent if you can avoid it.
And the hybrid approach, combining surgery and percutaneous.
Yeah, that involves doing both types of procedures in the same setting, often in a special hybrid operating room. Maybe you do an angiogram, then balloon and outflow stenosis percutaneously, and then surgically revise an inflow stenosis all at once. It can be really efficient.
Okay, now the really acute problem, the access clots off completely. Thrombosis. How is that handled?
It differs a bit between fistulas and grafts. Thrombosed fistulas can be trickier to salvage long term. Often there's an underlying issue with the vein itself that led to the clot. Just taking the clot out might not fix the root cause, and it can clot again quickly.
So surgery isn't always done.
Historically, surgeons were hesitant. But more recently, surgical thrombectomy for fistulas, especially if the clot isn't too extensive, has shown some decent results, and it saves the native vein, which is valuable. Percutaneous clot removal techniques are also used, but long-term data is still building.
What about thrombosed grafts?
Grafts actually thrombose more often, but they're often more salvageable. The usual culprit is that venous anastomosis stenosis, which we can usually treat. Grafts also tend to tolerate the mechanical clot removal better. Sometimes you can even replace a bad section of the graft. There's even interest in using early cannulation grafts to avoid temporary catheters when an access clots.
So what are the actual techniques for removing the clot, surgical and percutaneous?
Surgically, you make an incision, usually over the suspected problem area, like the venous anastomosis. You use a special balloon catheter, a Fogarty, pass it through the clot, inflate it, and pull the clot out. Then you must fix the underlying stenosis, usually with a patch or interposition graft. Increasingly, they might do the clot removal surgically and then fix the stenosis percutaneously in a hybrid fashion. Often, the access can be used right away after surgery.
And percutaneously, how do they get the clot out through a needle?
Several ways. First, you usually treat the underlying stenosis with balloon angioplasty. Then, for the clot itself, you can use thrombolytic drugs, clot busters infused directly into the clot. Sometimes you let it sit for a bit, lace and wait, or you combine it with mechanical methods, lice and go.
Mechanical methods, like devices.
Yeah, there are various devices designed to break up or suck out the clot. Things like the Fogarty catheter used percutaneously, rotational devices like the cleaner or Turritola, or pulse spray devices like Angiojet. No single device has proven clearly better than others.
And after the clot is out,
you absolutely have to treat the underlying stenosis, usually with high-pressure balloon angioplasty. Cutting balloons might help for tough ones. Covered stents might be used for recurrent stenosis, especially at the graft vein connection or in central veins, but again, cost is an issue. For really bad central vein blockages, sometimes a major surgical bypass like the Hero graft is needed.
what about hybrid for thrombosis?
Similar idea. Maybe remove the clot with a surgical balloon catheter through a small incision, then do an angiogram and balloon the stenosis percutaneously, or vice versa. It potentially minimizes clot going to the lungs, which can happen with some percutaneous devices, and might preserve more vein than pure surgery. Still need more data on long-term outcomes, though.
So with all these options, what's the bottom line on treatment outcomes? Is one approach clearly best?
You know, it's tough to say definitively. There aren't that many great head-to-head long-term studies comparing everything. Most comparisons look at open surgery versus percutaneous methods for thrombosed grafts, and they seem pretty comparable in outcomes.
So technique matters less than fixing the problem.
It seems the most critical things are successfully removing the clot and successfully treating whatever caused it, that underlying stenosis usually. The specific way you get the clot out might be less important than making sure the flow is restored and the underlying issue is addressed. The best approach really depends on the specific patient, the access, the problem, and, frankly, the skills and resources available at that center. It's still an area with ongoing debate.
This has been incredibly insightful, a real deep dive into a complex world. So, to wrap up, the big challenges seem to be that relentless intimal hyperplasia,
Yeah, that constant battle.
the many ways accesses can fail, and just how vital it is to catch problems early.
Absolutely. And we've seen there's a whole toolkit of interventions from traditional surgery to these advanced, minimally invasive techniques and the hybrid approach finding its place.
And it really hammered home that there's no single best way. It's got to be individualized, patient, access type, the specific problem, the team's expertise all play a role.
Exactly. And the field keeps evolving, which is good. Research on things like drug-coated balloons, long-term outcomes of different strategies, it's moving forward.
So maybe a final thought for everyone listening. Given how complex this is and how much it impacts quality of life, how can patients become, more empowered partners in managing their own access
Yeah.
and developing that care plan?
That's a really important question. Definitely something worth thinking about.
Indeed.
Yeah.
Well, thank you so much for sharing your expertise today. This has been incredibly valuable.
My pleasure. Glad to discuss it.